So let's start with cardiac remodeling. Let me set the whole, the ball rolling. There's a central pathophysiology to heart failure. Whenever there is a heart failure or a heart damage, actually what happens is the myocardium starts remodeling. It is defined as a group of molecular, cellular, and interstitial changes that manifest clinically as change in the size of the LV, the mass of LV, geometry, and function of the heart after the injury to heart. And this injury could be because of inflammation, because of ischemia, or because of chemicals and drugs. Whenever we talk about this injury, we have the heart goes into remodeling, which could be early remodeling and a late remodeling, which ultimately leads to neurohormonal activation of the sympathetic nervous system and RAS, and also dilatation of LV wall and thinning of the LV wall, and also scar formation. This all results in poor prognosis because of the association of left ventricular dysfunction, and it is known for a long time that poor LV begets more deteriorating LV dysfunction. So let's go on to the case-based discussion. This is a case scenario on heart failure patient showing changes in echocardiographic parameters. Seema, 68 years old, female, a known patient of Heifereff since 3 years. She underwent revascularization 8 months back. She was on optimized dose of ACE inhibitors and ARBs, beta blockers, and MRAs. But lately she complained of difficulty in breathing and difficulty in doing day-to-day course. On investigation, we found that the LV function EF was 32%. The Antiprobe ENP was 1782, which was markedly raised. The LV end diastolic volume index was 82 ml per meter square, and LV end systolic volume index was 44 ml per meter square. The clinical investigations definitely indicated that there are changes in the echocardiographic parameters, and there is progression of LV remodeling. And the question came, how does a cardiac remodeling impact the progression of heart failure in this patient? So as we see, cardiac remodeling is the culprit for heart failure progression. This has been known for a long time. And what we see, that patient with only a mild symptoms, like in this patient, does not mean that the heart is only mildly affected. What happens is, it's like a tip of the iceberg. The main problem is happening subclinically, and there is a huge amount of cardiac remodeling which is happening, and there is a continuously reduced pumping of the LV, and the LV functions actually keep deteriorating in the background, and the patient suddenly, if you do not control and arrest this process or retard this process, the patient would come with burnt out disease and severe heart failure. So be very careful. Even mild deterioration of symptoms and early rise in Antiprobe BNP or LV falling of LV functions post revascularization means that this patient is remodeling in the wrong way, and this will actually create a long-term bad prognosis in the long term. Now, this remodeling further worsens heart failure, and then there are many sites of many things which are happening. What is happening clinically? There's a prolonged LV relaxation time, increased diastolic stiffness, slow LV filling, and elevated end diastolic pressures, which are picked up on biomarkers as raised Antiprobe BNP. In terms of pathophysiology, there is eccentric hypertrophy, extracellular matrix remodeling, necrosis, apoptosis, autophagy, oxidative stress, and energetic abnormalities. And this leads to, in Heifereff patient, leads to cardiac changes in cardiac structure, myocardial composition, myocyte deformation, and multiple biochemical and molecular alteration, which all have a very negative impact on heart functions and cardiac reserve. So the understanding the features of cardiac remodeling has become a major objective for limiting or reversing its progression. That is where the crux of the discussion is. If we can intervene at this stage, we can actually prevent rapid progression of cardiac function and also prevent a burnt out stage. requiring LVADs or cardiac transplants or a lot of things in that direction, or CRTD. Now, if you have to understand, that there could be physiological and pathological stimuli which affect multiple tissues. It could be directly cardiac myocyte, interstitial matrix, or vascular smooth muscles and endothelium. And there could also be myocardial injury, which could be direct necrosis, scarring, thinning, or hypocontractility. And in the non-infarcted zone, it could be hypertrophy, dilatation, and hypocontractility. There could also be altered cellular pathways, pathway signaling in terms of which can lead to apoptosis, beta, dysregulation of beta adrenergic receptors, excitation of and contraction coupling, and also lead to changes in the myocardial oxidative mechanism and leading to myocardial stress. And there could also be changes in myocardial mass and volume. This is detected by echocardiography, as in this case, or it could also be detected by very early by cardiac MRI and radionuclide ventriculography. We had a similar case discussion on cardiac imaging a few hours back. And it could also be seen grossly in terms of fall in ejection fraction or changes in LV and systolic volume and diastolic volumes. So what happens once we know this, a decrease in LVEF in a revascularized patient significantly increases the risk of cardiovascular death and future hospitalization. If this is the data from CHARM study, which enrolled almost 7,599 patients. And what was seen is there was 45% increase in cardiovascular death and chronic heart failure hospitalization. And a fall of 10% of ejection fraction actually led to 57% increase in cardiac mortality or MACE. An increase in LV end diastolic volume or end systolic volume significantly increases the risk of patients for further hospitalization for heart failure or death. And this is the data from Valiant study, which enrolled 610 patients. And what was seen here is the death, cardiac mortality, and heart failure hospitalization actually increased by 15% if the end systolic volume went up by more than 10 ml, and it was increased by more than 9% if end diastolic volume went up by 10 ml. So with this background, and I have sort of given you a background of what happens in cardiac remodeling, how it affects the cardiac functions, the rehospitalizations, and further CHF and death in these patients. There is also a very strong correlation between the cardiac remodeling and the renal dysfunction, and I will direct the talk and discussion to Dr. Vijay Kher, who is a very accomplished and one of the senior most nephrologists of the city. So, Dr. Kher, if you want, I can move your slides, or if you want, you can move your slides yourself. Dr. Kher, are you there?
Dr. Kher, you are muted.
Yes, I am here, Dr. Khanna. Thank you very much for the invitation, and I would request you to move my slides, because then it becomes a continuity. Okay. Otherwise, it would break often, because I'll have to come 2 or 3 questions which are there.
Okay, so I'll keep moving the slide.
Yes,
and,
yes. You
Dr.
can
Yadave,
start.
Do you want me to move your slides as well, or you want to do it yourself?
Please go ahead, Dr. Khanna.
Okay, fine. So these are your slides, and the point of discussion would be relation between cardiac remodeling and renal dysfunction.
Yeah, I think there is a crosstalk between the kidney and the heart, and it's a very, very close kind of an interaction which happens even in health, and it gets aggravated in disease process. Acute dysfunction of heart can lead to acute dysfunction of kidney, and chronic dysfunction of heart can lead to chronic dysfunction of kidney or an acute dysfunction of kidney. So there's a vice versa kind of an relationship between acute heart failure and kidney dysfunction. And this is mediated predominantly by common mechanisms like sympathetic activation, renin-angiotensin system activation, oxidative stress, as well as. So there is a significant connection, a decline in kidney function aggravating the heart failure, and a declining heart function producing progressive decrease in the perfusion to the kidney and causing not only acute kidney injury as well as chronic kidney disease. Next slide, please, Dr. Khanna. Yeah, the heart failure coexists with kidney failure, and there is in fact 20 to 40% heart failure patients have serum creatinines of more than 0.3 milligrams per deciliter. About 50% patients of heart failure have some form of chronic kidney disease. And in this study, about less than 60 ml of GFR, about 50 to 66% of patients of heart failure had some form of kidney disease. And in addition, 20 to 30% of patients of heart failure, especially in acute heart failure, will have acute worsening of kidney function, either as a part of the heart failure or as a part of the treatment of acute heart failure. Vice versa, patients of chronic kidney disease, again, 30 to 40% of patients will have some form of heart failure. And in advanced kidney disease on dialysis or stage 4, stage 5 kidney disease, almost 50% of patients have heart failure. And this remains partly underdiagnosed because volume overload and heart failure distinction in patients of advanced kidney disease may not happen very easily. Next one, please. And you can see that the mechanisms which are important for causing this cardio-renal interaction and this combined heart failure and kidney failure is related to the common risk factors which are very common for both heart disease as well as for kidney disease: diabetes, hypertension, obesity, smoking, dyslipidemia, and other factors being malnutrition and immune-mediated diseases like or elevated augmented sympathetic nervous system or renin-angiotensin system, and other factors are like inflammation, endothelial dysfunction. These are fairly common both in patients of kidney disease as well as there is also in addition other toxic agents that treatment, under treatment of diseases of heart failure, which Dr. Khanna was talking about just now, and as well as under treatment of kidney disease. And then there are certain organ-specific factors which are common between heart and the kidney. And these are decreased cardiac output, renal perfusion is decreased in these patients, there is increased blood pressure in these patients, volume overload occurring in these patients, and then in addition there is leading to electrolyte and metabolic disturbances which occur in these patients. Next one, please. So I think you can see that renal dysfunction not only is affecting the function of the heart, but there is alterations in the structure of the heart also. And the cardiac remodeling, which occurs in patients of heart failure, is aggravated in patients who have associated chronic kidney disease. And this is related predominantly to increased atherosclerosis, which occurs in patients, diabetes mellitus being a common cardiovascular, as well as renal dysfunction, arterial hypertension, and wasting of protein energy, malnutrition, and cachexia, which are common in patients of heart failure as well as in patients of kidney disease. And these factors, in addition to chronic kidney disease as anemia, which is common in patients, and this aggravates heart dysfunction, as well as structural alterations in patients of chronic kidney disease who have significant anemia get altered. And these are related to many metabolic factors or changes which can happen in these patients. So there is increase in cardiac hypertrophy in patients of chronic kidney disease, as well as increased fibrosis in these patients. The endothelial dysfunction is again much more aggravated in patients who have combined kidney failure as well as heart failure, and the vascular stiffness and vascular calcification, one of the most common causes of calcification of valves as well as arterial and valvular and vascular calcification, is in patients of calcium phosphorus metabolism led by the progressive kidney failure in these patients. So this is how the cardiac remodeling, both in function and structure, happens in patients of combined kidney disease and heart failure. I think it's over to you, Dr. Khanna. I think that's probably the last slide for this. Dr. Khanna, you're muted.
That was very well explained, and now we move on to Dr. Yadave. Does cardiac remodeling impact outcomes in Heifereff patients post revascularization? I'm talking particularly in this context after bypass, because this is one of the very common situation we feel we face sometime. You have a good surgery or you have a good revascularization, but in the post-op period, over a few months, you see the LV is getting down and the patient is having early symptoms of heart failure. So I'll ask Dr. Yadave to discuss this point.
Thanks, Dr. Khanna. I mean, the short answer to your question is yes. Can I have the slide, please?
Yeah, it's there.
Yeah. So, if you look at when you have initially to start with primordial risk factors, that's the hypertension, dyslipidemia, smoking, and those kind of things, insulin resistance, it causes endothelial dysfunction, and ultimately it produces a milieu of atherosclerosis, producing myocardial ischemia. Now, till such point, no structural damage occurs in the heart, and all of these are producing symptoms, maybe stable angina, but there is no myocardial necrosis. But once the plaque ruptures for some reason and coronary thrombosis takes place, that's the time when myocardial infarction sets in, and it leads to a spiral of cardiac remodeling, which involves ventricular dilatation, ventricular hypertrophy to maintain the cardiac output, and formation of scars. And ultimately, if not interrupted and corrected, it leads to heart failure. Next slide, please. Now, if you look at the results from the XIII trial, when you have a normal ejection fraction and even mild derangement of ejection fraction, the primary endpoints after revascularization are nearly the same. But once you cross that tipping point, which is roughly 35 to 40% ejection fraction, see, there is virtually a doubling of the primary endpoints, and these primary endpoints I'm referring to are the all-cause mortality, the stroke, and the myocardial infarction. So virtually twice as much mortality and heart failure revascularization and MI if you have severe LV dysfunction as compared to mild LV dysfunction. Next slide, please. Now, if you look at these individual endpoints, they are affected both in short term as well as in long term. You look at death, look at heart failure hospitalization, and they are partially more affected in PCI as compared to CABG, but both of them are adversely affected. So heart failure is extremely important, and in fact is more important. Next slide, please. I sent some slides which have not been received. So if I can just add in, Dr. Khanna here, that we have been only talking of ejection fraction. There have been articles which have shown that ejection fraction is important, but probably more important is presence of heart failure. And it has been demonstrated in a very recent study, a very important study by Sun et al., that if a patient has preserved ejection fraction, but heart failure, they do much worse than patients who have reduced ejection fraction, but no heart failure. So it is extremely important that though the ejection fraction and heart failure may go hand in hand, but there may be occasions when the ejection fraction is preserved, but there is heart failure, and that is a very, very, what shall I say, a bad set of patients. Thank you. Over to you.
So that was very well explained. And now let's see what is the impact of sacubitril-valsartan combination on cardiac reverse modeling. in hospital patients. So this is a very new concept. We know that the remodeling happens, and at some stage before the tipping point, we can actually reverse this remodeling and correct this pathophysiology of remodeling at multiple levels. And whether we had many drugs which were there, ACE inhibitors, what is this? What happened to my slides? Okay, so we had a lot of drugs which were classical drugs like ACE inhibitors, diuretics, MRF, but the new drugs which have come to our armamentarium are, sacubitril valsartan combination and also SGLT2 inhibitors. These are the two game changers which can actually reverse this remodeling effect. And I'm going to be talking about sacubitril valsartan in these patients. Not only that, this combination improves cardiac remodeling by inhibiting myocardial cell death and hypertrophy, it also sort of increases the longevity of these patients and somehow also increases the LV ejection fraction. Now, what happens here is the sacubitril increases the cardiac myocyte decreases the cardiac myocyte contractility and decreases the cardiac myocyte death, while valsartan leads to cardiac myocyte hypertrophy and also LV extracellular matrix remodeling, but reduction in these two. And this leads to cardiac remodeling in a way, in a reverse remodeling, which actually improves the LV functions. The beneficial reverse cardiac remodeling effects with sacubitril and valsartan have been demonstrated in multiple studies in Heifereff patients, not only one, but many studies. And what we have seen that this benefit actually starts very early, and it's a long-lasting benefit. And LVEF almost improves by 5% in most of the studies, and we know that this 5% improvement in LVEF in hospitalized patient actually translates to a much bigger improvement in the survival of these patients. The data from prospective open-label single-center trial, which included 68 patients of acute decompensated heart failure, it was seen that this combination improved ejection fraction by 8%, and there was no improvement in EFs by ACE inhibitors and ARB. We are talking of a subgroup of hospitalized patients with ADHF. It improved the echocardiographic parameters of in-hospital patients, and this is the data from prospective open-label single-center trial, and again enrolling 68 patients of ADHF. And what we see here is there has been improvement in the indices from and parameters of echocardiographic, both in terms of decrease in end diastolic volume, decrease in end systolic volume, and also improvement in E to E prime, which is an indicator of diastolic dysfunction. Again, this study showed that there was 42% relative improvement in with this combination compared to only 1% improvement with ACE inhibitors and ARB. And it is recommended by ACC and ACC in 2021 that for all hospitalized patients with Heifereff, this combination should be the first line of treatment, along with other decongestive therapy in patients with Heifereff who have been admitted with acute decompensated heart failure in the hospital. The ESC guidelines of 2021 recommends ARNI as a first-line therapy in Heifereff patients, and we know why it's recommended. It is a cornerstone therapy for Heifereff patients, and this has been proved beyond doubt by different studies, by different guidelines, be it European, American, or WHO guidelines, and also the Indian guidelines, and this is what we have seen even in our day-to-day practice. So now we come back to Dr. Kher and to discuss whether this combination improves heart function in Heifereff patients and CKD patients.
Thank you, Dr. Khanna. As you can see in this slide, actually, sacubitril valsartan significantly improves heart function in real-world Heifereff patients with chronic kidney disease. This is real-world data, 54 patients. On the left-hand side, what you see is the historical controls, and this is at baseline in gray, and then darker yellow is about 6 months and 1 year of treatment. So you can see that there is improvement with the standard of care. This is the historical controls which were available prior to availability of sacubitril valsartan. And with the availability of sacubitril valsartan in these patients, you can see that there is an increased improvement in the percentage of people who improve their left ventricular ejection fraction in patients with chronic kidney disease. These are difficult group of patients who have chronic kidney disease. Heart failure alone, and then in addition, chronic kidney disease obviously makes these patients extremely difficult to show improvement. So improvements have not been very easy in this group of patients, and sacubitril valsartan showing a significant improvement is definitely a good impact of this drug in patients of chronic kidney disease. These are worse patients. Next one. And you can see that actually sacubitril valsartan, and this is a sub-study of the paradigm heart failure study, which included about 2,745 patients. These are patients who had an GFR less than 60 ml. Paradigm heart failure had included patients up to about a GFR of 30 ml or so. They did not go below 30 ml. So these are group of patients who had GFRs between 60 to 30 ml. And you can see that this is in comparison to enalapril. And you can see that there is a 21% reduction in cardiovascular death or hospitalization for heart failure. There is again a 24% reduction in cardiovascular death, 21% reduction in hospitalization for heart failure, and all-cause mortality, again, a 21% reduction, and 30% reduction in the development of end-stage kidney disease. So you can see that not only there is improvement in the mortality in patients with either heart failure admission or cardiovascular death, all-cause mortality, development of end-stage kidney disease. So these parameters are significantly improved in patients with the kind of standard of care. You can see that the ACE and ARBs in heart failure have already improved the mortality rates by about 18% or so. You are about 34% increase in the survival of these patients. And in patients with heart disease and kidney disease, this is a significant kind of a paradigm shift in the management of these difficult patients. Next one, please. And not only you can see what is significant in this patient, which is extremely important for nephrologists, and look at the impact on the decline in the GFR. With enalapril, you would, starting say at a GFR of 63 ml, you'll see that in 1 year time, there would be a decline in GFR to about 56 ml or so. So 7 ml decline in GFR. But with sacubitril valsartan, you start almost with the same similar kind of a GFR, but the GFR improves by about 7 ml. So in fact, there is an improvement of about 14 ml of preservation of kidney function in these patients who otherwise would have progressively progressed to advanced kidney failure. So sacubitril and valsartan definitely brings a huge advantage to patients who have significantly severe disease with very, very high mortality and very, very high morbidity in these patients. These people get admitted very, very frequently to the hospital. So sacubitril valsartan, a great, great addition in the management of these patients, difficult patients. Over to you, Dr. Khanna.
So we see this drug has a potential not only to increase the cardiac function and the ejection fraction, we also see that it has the potential to increase the kidney functions and the GFR, and probably this happens because it's acting in that loop of cardiorenal syndrome, and better LV functions actually lead to better renal perfusion and better kidney functions. Now, what is the impact of this combination on Heifereff patient with after revascularization? Again, we come back to Dr. Yadave. And
well, the effect, carries on. It is not just limited, as Dr. Vijay said. The benefits occur in the kidneys, they do occur in the heart and the entire vascular system, and they do remain even post-revascularization. In fact, if you look at the same study that Dr. Kher was referring to, and we're going to refer to over and over again, the paradigm heart failure study, even in this patient who did not have any coronary revascularization, there was a roughly 17% improvement in or reduction in cardiovascular death and heart failure, the composite endpoints. But if the patient had undergone coronary revascularization, this benefit got exaggerated to 26%. So there was a 26% reduction in the composite endpoints. Next slide, please. And if you look at the breakup, now this occurs both early as well as late, and it is irrespective, as I told you, of the revascularization status, and there is 20% reduction in cardiovascular death. So the composite endpoint was driven mainly with hard endpoint of mortality, and that is very important. Reduction of MIs, strokes, and those are important, but not as hard endpoints as mortality. Next slide, please. We also see that the composite outcomes, and these composite outcomes included, things like MI, stroke, resuscitated cardiac death, as well as cardiac arrest, as well as cardiac mortality and all-cause mortality. And there was a reduction from 20% to 17%, which is a kind of a 17% relative risk reduction in the composite endpoints. So it's important to realize that post-revascularization remodeling is extremely important for satisfactory results of a revascularization. Otherwise, no matter what great a job you have done, the patient may have functional graft, but his ventricle fails, then the problem, in fact, not only remains, it worsens. Is that all, I suppose? And, I've already spoken this. This is reduction both in cardiovascular death and heart failure hospitalization. Even if you look at the individual components and you look at early as well as late, this reduction is compared to the use of just ACE inhibitors. And in the paradigm heart failure, as Dr. Vijay Kher had already told, the comparison was made with enalapril versus the ARNI inhibition. Thanks. Next slide, please.
Okay, so once we are clear about this fact that, ARNI is important both in improving LV functions and also improving renal functions, it is a must post-revascularization if the LV is poor. It could mainly in Heifereff patients, but also in HFpEF patients, as told by Dr. Yadave. Does Antiprobe BNP play a significant role in cardiac remodeling in Heifereff patients? Now, it is Antiprobe BNP, which is one of the most common biomarkers which we use in our clinical practice, is a prognostic biomarker in Heifereff patients. And most of the studies and the trials which we have seen now, actually, one of the endpoints is a change in the Antiprobe BNP level. And this is released from the myocardium in response to hemodynamic stress. It provides prognostic information in Heifereff patient, and decrease in its concentration improves shows that there is an increase or increase in the improvement in the heart failure or LV ejection fraction or the LV stress. Its level independently predicts clinical outcome post-discharge in hospital patients. And if Antiprobe BNP did not decrease by 72 hours, the patient are at a risk of, there's a 75% increase in the risk of death or hospitalization within 30 days, and 4-fold increase in the risk of death at about 6 months. So ADHF patients without a significant fall in NT-proBNP levels merits closer surveillance post-discharge. And obviously what it means is these patients have not been adequately treated in hospital or before discharge. And these are the patients who are going to come back again with repeated hospitalization and repeated heart failures. And we need to know every repeated heart failure hospitalization is an independent predictor of a worse prognosis in terms of mortality and MACE. So what are the impact of change in NT-proBNP on cardiac remodeling parameters? Numerous heart failure therapies like sacubitril valsartan are associated with reduction in NT-proBNP in parallel with reverse remodeling. So what happens here is not only that the NT-proBNP levels have linear correlation with improvement in LV ejection fraction, also they have a linear correlation with decrease in LV end diastolic volume and LV end systolic volume, and also the clinical condition of the patient and the NYHA class. ARNI reduces death and heart failure hospitalization by reducing NT-proBNP. It is not by reducing NT-proBNP, it is by adequately decongesting the patients and improving the heart failure and improving the cardiac remodeling. And this NT-proBNP is an indirect biomarker suggesting that this improvement is happening. So it's not because of NT-proBNP, but NT-proBNP is a marker. Fall in this NT-proBNP is a marker of improvement in cardiac functions. Now, what is the impact of ARNI on cardiac reverse remodeling in Heifereff patients with FMR? I'm going to direct this discussion again to Dr. O.P. Yadave.
Well, cardiac remodeling obviously is extremely important, and what it does to the ventricle is that the ventricle dilates. It also changes its shape. So from an typical elliptical left ventricle, it becomes spherical. And when it becomes spherical, what happens is that the mitral valve gets tethered. That is, the chordae are pulled laterally instead of longitudinally, and the closing forces of the mitral valve and the tethering forces of the mitral valve start competing. As long as the closing forces are strong, the mitral valve remains competent, but moment the tethering forces take over, the mitral valve becomes incompetent, and left ventricular remodeling as well as left atrial remodeling, that increases the mitral regurgitation whenever it is a functional MR. So in that way, it is extremely important that we control the ventricular remodeling, and that is why we say functional mitral regurgitation is a ventricular problem. It is not a valvular problem. Next slide, please. So the first and foremost is guideline-directed medical therapy. You know, European Society of Cardiology and Cardiovascular Surgery just a couple of weeks back or 10 days back have released their valvular heart guidelines 2021, just 10 days back. And they've given class 1 recommendation for guideline-directed medical therapy. And it is not only ARNI, but it is also, SGLT2 inhibitors and ivabradine. And they must replace ACE inhibitors and ARBs, even if the patient is so-called stable. In fact, the word used is there is nothing like a stable heart failure. So we must, even in patients who do not have symptoms, we must transition to ARNI oblique, the SGLT2 inhibitors as the need may be. Next slide, please. Now, it has been shown in the PRIME study that systolic and systolic volume and diastolic volume, as well as index volumes, they reduce by more than 2 times with ARNI as compared to the ACE inhibitors. Next slide, please. And if you look at effective regurgitant orifice area, there is a reduction of almost 3 times. Next slide, please. And regurgitant volume of the mitral valve also, reduces by almost 3 times or 2.5 times. So there is a gross remodeling benefit in these patients. And surgery or any form of intervention must only be considered if a patient has been adequately treated with guideline-directed medical therapy, and which includes ARNI and SGLT2 inhibitors. I think I've finished. Thanks.
That's a very important learning, that even in functional mitral regurgitation, because of LV dilatation and ARNI is a very important and a first-line drug, and it's now recommended by the European guidelines. Now, what is the safety profile of this drug in hospital Heifereff patients? In terms of the nephrologist point of view, Dr. Kher, I'll direct this discussion to you.
Yes, Dr. Khanna, as is evident in this slide, actually worsening renal function is very well known to cardiologists as they start treating patients with heart failure. There is worsening of renal function as the heart failure progresses, and there is also worsening sometimes in patients when you start treating and removing the fluids with diuretics, and there is a diuretic induced increase in the serum creatinine and the urea. And when you look at sacubitril valsartan in patients of acute heart failure, and this is from the Pioneer heart failure study, you can see that there is an 11% reduction in the incidence of worsening renal function. And worsening renal function, you must realize, is associated with increased morbidity and mortality in patients of heart failure. So in comparison to enalapril, there is a 11% reduction in the incidence of worsening renal function when you switch patients on to sacubitril valsartan from enalapril. Next one, please. And the incidence of hyperkalemia, also hypotension, is also reduced in these patients. Hypotension is a significant adverse effect in the treatment of heart failure patients, and with sacubitril valsartan in the Pioneer heart failure study, you can see that there was a 27% reduction. The incidence of hypertension in enalapril was about 4.6%, and it was 3.4% of patients on sacubitril valsartan. So 27% risk reduction of hypotension with sacubitril valsartan in comparison to enalapril. And next one, the incidence of hyperkalemia. Next one. The incidence of hyperkalemia in the hospitalized patients. When you look at enalapril, one of the common complications of treating with enalapril would be incidence of hyperkalemia, and sometimes severe hyperkalemia in patients of heart failure. And in patients associated with kidney dysfunction, the incidence of hyperkalemia becomes much higher. The overall incidence of hypertension, hyperkalemia was reduced in the Pioneer heart failure study by about 41% once you moved patients from enalapril to sacubitril valsartan. So significant improvement in the adverse effects related to sacubitril valsartan in comparison to enalapril. Next one, please. So I hand it back to you, Dr. Khanna, for you to summarize this whole case discussion.
This was a really good discussion, discussing about the entire spectrum of heart failure in a revascularized patient with renal dysfunction, and how this new drug helps in different ways, and what are the different mechanisms it works on, and also what are the clinical scenario where ARNI is important. So let me just summarize what we discussed. In a Heifereff patient showing changes in echocardiographic parameters like this patient SEMA, time is very essential. So one has to be very, very critical that you need to initiate these therapies and get the patient better before you discharge the patient. And so to initiate ARNI as a first-line therapy in heart failure, we must have the confidence, not only because it improves the heart function and the remodeling in hospitalized patients, it improves clinical outcomes in Heifereff patients post-revascularization, and it is also a very safe and well-tolerated drug for in-hospital Heifereff patients. And what we need to understand that there are a lot of people who are worried that, it may cause symptomatic hypotension. As we saw, the risk of hypotension as compared to other ACE inhibitors is much lower. And even if the patients do have a fall of blood pressure, they actually feel much better. They are better in terms of NYHA functional class, and they improve in terms of parameters of heart failure, whether they are the echocardiographic parameters or they are biomarker parameters. So with this take-home message, I'll probably stop here. And I thank my co-discussants, Dr. O.P. Yadav and Dr. Vijay Kher, for making this discussion very fruitful and with a very clear-cut, take-home messages. Thank you very much for staying back and for attending this APVIC. It means a lot to us.
Thank you.
Thank you. Appreciate it.
Thank you.